Good morning. I'm just waiting for all the participants to join. I see the numbers going up. We're at about 70. Still ticking up. All right. I think we've let the majority of the folks in. I see 95 participants, and I'm sure a few will trickle in. Welcome to our second special summer grand rounds to include COVID-19. So we have two more coming up during the summer. It's in 2 weeks, August 13th, and then 4 weeks, August 27th. And then after Labor Day, we go back to our usual schedule of weekly grand rounds. So we have a fair amount to cover today, but very quickly, for those of you who have not done this kind of format, if you're in the audience, you can hear and you can see us and you can see the slides. The way for you to participate by asking questions is by using the Q&A button. Please try not to use the chat button, use the Q&A to ask questions, and I will compile those and ask them of our panelists at the end of the talk. So without further ado, I'm going to start with Dr. Lesho's presentation. I think you can all see his slide at this point. Epidemiology update, Dr. Lesho.
All right, thank you. Thank you for giving infection control and infectious disease a few minutes of your time. Not only is this going to be the daily double round, it's going to be the speed round. So fasten your seatbelts. So what you've got to think about is I'll say the following bullets and then you try to answer the question. And you don't have to worry about responding, just scream real loud wherever you are. So apple processing factory in Oswego, aluminum extrusion company, Fonda, and a rock quarry on the eastern border of New York by Vermont. And you have 2 seconds to answer, 1, 2. So what you need to say was, what were the locations of recent employer-based outbreaks in New York City, large outbreaks? One of them involved 250 workers. So even though New York State is doing very well, there are hotspots that continue to pop up, and especially concerning are some high-risk workers. Okay, 5% to 40%. The answer to that is, what is the reported false negative rate of the RT-PCR that we use to diagnose COVID-19? And that's important because if you're on a pessimistic side of the house, kind of like I am, and you go to a higher 40%, that's why we have certain infection control practices in place related to aerosol generating procedures. All right, 14 days, 21 days, 3 months. And then another way to look at it, 24/9, 34/26, and greater than 40/36. So what are, according to our upcoming discontinuation guidelines, which are provisional, how long the patients have to stay on isolation precautions? So we're trying to keep it simple. So this is for hospitalized patients. If your mild disease, as defined by never having spent any time in an ICU or step down, you can come off isolation precautions in 14 days if you're getting better. If you ever set foot in an ICU or step down, it's 21 days. If you recover a COVID infection and for some reason you're tested and your test is positive and that was within 3 months, that's considered part of the same infection. So we're not going to put you on lockdown. That's not considered a new infection as long as it's within 3 months. And the few locations that had the ability to do cultures, actual viral cultures, because we keep in mind, all we detect is the signature, is the DNA signature in somebody's respiratory secretions. They have found that, and they correlated that with what's called the cycle threshold. So they took a respiratory sample from somebody, they did the PCR, they recorded the value of the PCR, and remember, the lower the cycle threshold, the more viral load is there, right? And so they had said that on day 8, that's when they achieved, nobody could culture the virus after day 8 to day 10 in most of those studies. And then another study looked at it and said, we could never culture the virus after the cycle threshold got higher than 24. So we did a prospective study here at RGH. We looked at 70 patients sequentially and took up to 5 or 6 weekly samples on those patients. And we found that on average, you would achieve a cycle threshold of 24 on day 9, which nicely correlates with the 8 days by the culture. Experts have said that it's safe to discontinue isolation precautions when the cycle threshold hits 34. Our data says that you'll hit that on day 26. And then if you wait until a negative test, you have to wait until 36 days based on what we observed and others. And that's why it's unnecessarily long, we're thinking of. So 1.5%, 0.2%, and 25%. What is the percent positivity rate in New York State? What is the percent positive of the patients that we would have not otherwise found? I mean, what that gets to is the number of patients that we are seeing, the percent of those that we are detecting based on testing all admissions. That was a sample over the last month. So that, you know, that the concern is that since the positivity rate is so low and since our detection rate is so low, is it worth the cost to continue to test all admissions, to continue to test all preoperative cases? Even though that's low, we argue yes. We don't have time to get into that. But the one main reason is that 25%. That's what I find very concerning. That's what we all find very concerning. The number of positive cases that are detected, newly detected in Monroe County, 25% are imported cases. In other words, they're associated with travel to Florida, to other high-risk states. And you see every day, those high-risk states are becoming more and more numerous, and more are going on the quarantine list. So travel from those states is a risk. And then hydroxychloroquine is safe and effective, alien DNA, and mask gave me COVID-19. That was recent misinformation put out by our current, presidential administration just in the last 2 days. So I'm going to end with my prediction and my opinion. People are wondering about school, as am I. I had read the CDC revised guidelines, and I'm not so sure it's worth your time reading it. I think, to put it politely, they are insufficient. They are underwhelming. We deal with federal and state guidelines since the beginning, almost on a daily basis. By we, I mean the incident command team, infection control, the quality people. Compared to the guidelines that we're used to getting that are highly detailed, that are specific, these don't offer any specific guidelines. And so I'm concerned that especially the public school systems, which are limited in funds, not get the adequate spacing, ventilation, et cetera, to make it a safe. I know it's important to get the kids back to school. My next prediction is there's a good chance that things are going to get a lot worse, especially in the fall. All of these other states, even though New York State is doing very well, it's not an isolated situation. People move, people travel. And for that reason, I would encourage, trying to get all your elective surgeries and your procedures and your is done now as soon as possible. Because this is just my prediction, but there's a good chance if we get so bad, we'll have to suspend elective procedures for a while. And so finally, take a moment to look at the slides that were given to the academic half day. We don't have time to go into that, but that all updates some of our latest. They were put together by Jennifer Gutowski. They're worth a read. Thank you.
Thanks a lot. Kathy, I'm going to let you put on your slides and introduce the next part of the talk.
Yep, I'm getting there. So my name is, I'm introducing myself, and Wade Norwood will introduce himself as well. I'm Kathleen McGrail. I'm a retired primary care doc from Rochester General. I practiced primary care for about 40 years. In my retirement, I've been really active in ongoing education for both residents and faculty, and that's local faculty as well as faculty of the Academy on Communication and Healthcare. Since COVID, I've been working on the SOFA scoring group, and I'm also part of the African American and Latino Health Coalitions at Common Ground Health. I do want to say one thing about my co-presenter, Wade Norwood. He's the CEO of Common Ground Health. And if you do not know about that agency, you are missing a very valuable partner in this community. They are, Wade and all of the people who work with him are a rare and very precious resource for our community. Now on to our topic today. I actually asked Prad if we could do this presentation because the medical literature that I read, which could be different from what you read, but in JAMA, in New England Journal, and Annals, there are articles all the time about the nexus between COVID and social determinants of health. And it seemed like this would be a good opportunity, actually an unprecedented opportunity nationally, but a local opportunity to bring data to you that you may not otherwise be able to access. And so that's why this grand rounds today. Our objectives, are that by the end of this time, you'll be able to define racial and health equity, unconscious.
You're not sharing your slides yet. Are you
I'm
sharing?
not sharing?
No.
Oh, okay, well, my slides are up, I'm sorry. Another glitch here. And show, share screen, I'm sorry. You have the slides?
Yeah, I can share.
Could you just share them?
Hang on.
So I'm just going to keep talking while Prad gets them up. So I'm going to start this talk with a metaphor before I go to the objectives. I'm going to say, imagine that there's a knock at the door. The knock is kind of weak. You're not really sure that you hear it. It would be a lot of trouble to get up and go answer the door to see if there's somebody really there. So you tell yourself you imagined it and you don't go to open the door. And that cycle repeats several times. Finally, the person outside the door gets really impatient and yells through the door, "Are you trying to tell me that you don't hear me? Really? Do I have to bust the door down? Or are you going to open it up and let me in?" I'm using this metaphor from my personal experience and how I became aware of disparities and inequities in health outcomes. I can't say anything about what your experience has been or will be or is currently, but the knocks on the door were the occasions of cognitive dissonance for me, times when observations reported by data reported by race and ethnicity challenged my theories or explanations about why there were differences in health outcomes, and challenged me in a way that suggested that my thinking wasn't right. And I have to say that most of the time that data came to me from somewhere else. It came to me from a colleague in Detroit. It came to me at meetings at the Institute for Healthcare Improvement. And in more recent years, it came to me from Common Ground Health. But the data didn't come to me from GRIPA or from RGH. The door is opportunity. It's an opportunity to learn something different, to improve. If I would just open the door, then something could change. The room I'm in is my privilege, which enables me to choose whether or not I want to hear the knocks and open the door. It's too long a story to tell you what all the knocks were on my door, but just to say this, that I had to open the door when I understood that it wasn't just somebody else's problem. It wasn't some other city, some other health system. It was in my practice and in my patients. And it had happened with one of my patients that I knew of. If it happened there, it could have happened with others. In the civil rights era in the 1960s, Martin Luther King said the greatest tragedy of this period of social transition is not the strident clamor of bad people, but the appalling silence of good people. And in 2001, psychoanalyst and poet Carol Estes wrote this: "In any dark time, there's a tendency to veer toward fainting over how much is wrong or unmended in this world. Do not focus there. The tendency too is to fall into being weakened by dwelling on what is outside your reach. Don't focus there. That is spending the wind without raising the sails. Ours is not the task of fixing the entire world at once, but of stretching out to mend the part of the world that is within our reach. So here's the ask from us to you today. As you listen to what we have to offer and thinking about yourselves as individuals working in healthcare, as leaders in education or in your departments, what are the knocks on your door? What is within your reach to mend? What will you do when you click on the leave button today and get up to take up your work for the day? Okay, do I have a slide yet?
We're going through the presentation. I'm on slide 5 or something like that.
Go to objectives. Okay, so we're hoping that you'll be able to define disparity, racial equity, structural, and institutional bias. I'm not going to address privilege. That you'll be able to describe social determinants of health, appreciate social determinants of health as the cause of the causes, and then be able to identify some anti-racist action steps. I'm going to do the first and most of the last, and Wade is going to do the middle two. Next slide. Next slide. Next slide. Next slide. Next slide. We cut things out so that Emil had time to do his presentation. Okay, so this is a really nice, pretty picture to look at. This is my second metaphor and my last. Imagine that the big fish on the left of the screen is an older fish, and the older fish is passing by 2 younger fish on the lower right. And in passing, the older fish says to the younger ones, "How's the water, kids?" And the kids reply, "It's terrific," and they swim on. A few minutes later, the younger fish turn to each other and say, "So, what's water?" The water is what most of us live in. It's a sea of unconscious bias. It's like the air we breathe. It surrounds us. It's always there, but we can't see it or touch it. In this image, what's even more apparent simply looking is that this is not open sea. The fish are swimming in a tank where they've always been and don't even realize that it's a constructed reality. In this metaphor, the tank is structural and institutional bias, which holds the system in place for all of us. Next slide. So now I'm going to expand on unconscious bias. And I'm going to say, why don't you just put them all up, Prad? Unconscious bias is not the same as explicit bias. Explicit bias is known to the individual, and it's often openly expressed, sometimes in ugly or threatening ways that we would identify as wrong, like it's anti-Semitic or racist or homophobic. This is really different from the individual with unconscious bias, who by definition is unaware of the bias, could not describe it if they were asked, and more frequently than not is dismayed to discover that they have unconscious bias that is in sharp contradiction to what they believe about themselves. We're not born with it, but experimental studies show that it's present in children as young as 3, based on color. And it's pervasive. The Harvard implicit test, as of a few years ago, was taken by over 700,000 people, and 75% of those folks have a moderate to strong pro-white bias. And when it's been done in physicians, the score distribution is the same as the general community. There are some exceptions, and the 2 exceptions are African Americans and women who also have pro-white bias, but tend to have it to a lesser degree than the general population. Now, even for people who are making intentional efforts to mitigate or control the impact of unconscious bias on their work, there are some things that are triggers for everyone, and they are time pressure, high cognitive demand, limited resources, and uncertainty. And that's part of the life of people in healthcare every day, and it's part of life in COVID time on steroids. One of the functions of unconscious bias is to make distinctions between us which is the in-group, and them, which is the out-group. And once you do that, or once that happens, the consequence is that everybody in the out-group is identified as being the same. There's no differentiating characteristics. Whereas if you're part of the in-group, there are fine distinctions we can all make between ourselves. Now, problem with unconscious bias is because you don't know you have it, you can't recognize it when you're actually experiencing it yourself or when you see it in someone else. So you have to be committed to trying to figure out how to see this and hear it. And I'm going to give you an example, because once you start paying attention and get sensitized to this, you will be surprised how often, and you will probably be dismayed by how often it actually appears in our day-to-day interactions. So this is an example that I heard in reference to patient satisfaction scores in federally qualified health centers. When I took this quote to a workshop in Arizona for a discussion, what I discovered is that there were 1 million versions of this. So although I heard this locally, there are many versions of this all the time everywhere. And the statement was, how can you expect their satisfaction scores to be good when the quality of their lives is so poor? So when I first heard that, first pass is, well, there's something about that that makes sense. And then the second very instant response was, there's something about that that's not right. And the first thing I knew was not right was, I even knew then, and this was about 6 years ago, that satisfaction scores correlate with clinical outcomes. So if you, and this is particularly true in the outpatient setting, if you give up on satisfaction scores, then to some extent, you're also giving up on improving clinical outcomes. The second is the word there, which appears twice. That's an example of the in-group versus the out-group dichotomy. So that's a sign, whenever that term comes up, is that we're in the unconscious bias space. The third point is that the person making the statement, I am certain they would never identify themselves as being racist, that this was unconscious bias leaking in the presence of frustration. And that person made a judgment about the quality of life for them as if they all have the same quality of life. There's no differences between them. And the standard for the judgment was what I think is a good quality of life. So I'm using examples here because these terms don't make any difference if you can't see them in your life. Next slide, Prad. You can fix this, but you have to work at it. Okay, so institutional instructional bias. What I want to say here is that unconscious bias and explicit bias exist on the individual level, which is what I've been talking about first, and it also exists on structural and institutional levels. And the presence of bias on any level amplifies and magnifies the impact of bias in every other level. So these are like cogs in a wheel that just keep building on one another. Institutional, excuse me while I find my notes here, institutional bias is built into the fabric of institutions. It's practices or procedures whose effect is to systematically disadvantage certain groups over others. So here I'm going to use another example. You could quarrel with the example, but I'm going to use it. Say you have a practice that is 80% minority patients, primarily African American and Hispanic. And then you get your blood pressure results for that, your blood pressure control results for that practice. And you see that you have a 50% control rate. And you're dismayed by those results and you intensify your efforts to improve control. Now, that would be normal. You want to do better. But if you used an equity lens to look at those results, you wouldn't simply intensify your efforts across all patients. You would say, who is in the 50% that is not well controlled? And you wouldn't just look at the individual patients in the 50% that's not well controlled. You would say, who are the groups in that 50%? Is there a group that I can identify? And so if you were using an equity lens, you would get results by race, ethnicity, language, age, gender, and then probably down to the level of the clinician. That way, you would expose subpopulations that need a different approach. For example, you might find that half of your uncontrolled patients fall into the group that has a Spanish language preference. So if you don't do things like that, then to not consider those factors in looking at quality or allocating resources could be examples of omissions and unconscious bias operating at an institutional level. It's also normative. It's always been that way. No identifiable person made any decision that was explicitly biased. It just happens that way. But doing things the way they've always been done isn't working for 50% of the patients. So you could be systematically disadvantaging both the clinicians providing the care and the patients by not looking at this differently. So inaction in face of need, acts as well as omissions, all of these things can fall into the category of institutional or structural bias. For structural bias, it's differential access to services or opportunities across multiple institutions, including education, employment, justice, policing, and healthcare. So they're additive. And you want to talk about people succeeding in an environment where everywhere they turn, there are impediments to their success in any endeavor. Next slide. So what is racial equity? Racial equity is the condition that would occur if one's racial identity no longer predicted in a statistical sense how one fares. And health equity is, these are formal definitions from the organizations I've listed. Health equity, defined by Robert Wood Johnson Foundation, is that we all have a fair opportunity to make the choices that enable us to live long and healthy lives, regardless of our income, education, ethnic background, or personal characteristics. Next slide. I think that might, okay. I'm gonna say two more things. What is disparity and what is inequity? Disparity is a difference in between groups in a population in either health care process, health or health outcomes, without regard to whether or not it is just or unjust. Inequities are those same differences when they are unjust and unfair. And with that, I'm going to transfer this to Wade, who's going to take us to the 30,000 foot level when I've been on a foot soldier level.
Thank you so much, Kathy, and good morning, all. I will try and make sure that I complete my remarks in about 10 to a dozen minutes, and I'll hand it back to Kathy, and she'll conclude, and then we'll have time for Q&A. Prod, if you wouldn't mind advancing. Again, my name is Wade Norwood. I am CEO of Common Ground Health, which is the health planning entity for the 9-county Finger Lakes region, and we see it as our mission to bring focus to regional health issues through our research, data analytic, our community engagement, and the collaborative partnerships that we build or in which we engage. And at no time has our work been as urgent or as pressing as in these unprecedented moments of the COVID-19 crisis. And as you can see, with regard to the case rate, what we're looking at as we make our way through facing this pandemic is really an expression of those health inequities that Kathy was just referencing. Proud if you would mind, and I would thank you all for making time for me this morning. Rochester Regional Health is an essential partner for Common Ground Health. You should know that Hugh Thomas, one of your senior leaders, is our board chair, and Dr. Weefling serves our board, and many of your colleagues have joined Kathy in being part of the more than 20 collaborative tables that we currently convene. And we believe that our work, if you wouldn't mind advancing, Proud, we believe that our work is really being underscored by the fact that Dr. Fauci was right. The health disparities that we're seeing with the coronavirus pandemic really are not new things. But what is happening is that COVID-19 is shining a light on the fact that the burden of disease is not equitably borne by the folks who live in our society. Next slide, please. And I know that this slide is not new for you, but I want you to understand how new and novel this is for your non-clinical partners. To understand that those factors that determine health outcomes and drive and fuel our health course trajectory are not medicine or connectivity to the healthcare system, but really what happens in society. It's our environment, it's our socioeconomics, and it is our behavior. And that if we are going to change health outcomes, understanding that we really need to change what's happening in the community really has been the tremendous gift that I've been given over the course of the last 15 years at Common Ground Health to help fuel and undergird a community understanding that healthcare medicines and doctors did not create our problem. And it is going to take new thinking and the engagement of all of us if we are going to achieve health equity. The next slide is really one of my favorite cartoons. Pictures are worth 1,000 words, so I'll show you some pictures and spare you having to listen to thousands of words from me. This is a map of the 9-county Finger Lakes region, our home, Lake Ontario to the north, the Pennsylvania border to the south. And this map of the Finger Lakes region is color-coded by zip code. And the color coding reflects the socioeconomic status of the folks who live in each zip code. SES is a composite measure that we create here at the agency that reflects the poverty rate of folks who live in the zip code, their per capita income, their educational attainment, the unemployment rate of the adults in the zip code, the type of occupation held by folks who live in the zip code, and the household composition. And the darker the color, the worse the folks in the zip code fare by those measures. If I had the luxury of time, this is where I would really make it an interactive conversation, and I would ask, what do you see? And I've been showing this slide for years. And what most astounds audiences is to reflect on the fact that although we think of poverty being a city issue, and folks are not surprised to see that really dark cross in the upper left-hand column, the heart of the city of Rochester, repeatedly, continuously, and still today, our neighbors are stunned to see the wide swath of poverty that exists across the region, to understand that poverty is not relegated to the urban corridor, but exists in suburban and in the rural parts of the Finger Lakes region. To truly understand that the face of poverty, my friends, doesn't look like my face, but it really looks like all of us. And Prod has been kind enough to advance to show you the same map of the Finger Lakes by zip code, but this time the color coding reflects years of potential life loss, reflects premature mortality. And I hope that you can instantly see what our neighbors see when I carry these slides out into the community. Poverty is killing us. And if we are going to achieve health equity, we're going to do so by recognizing the role that poverty plays and the need to address the socioeconomic reality of our region. Prod, if you wouldn't mind, sir. This is really a chart that really reveals what we just saw in the map. That there is a strong association between wealth and health. and we've got to make health last a lifetime. And we've got to make sure that the lifetime is not the lifetime of my cousin Reggie, who died at age 40, but really the lifetime of my dad's mom, his grandmother, who had the chance to live to a ripe age of 93. Next slide, please. We've been spending a lot of our time at the agency researching the what's behind health status. And it's only been in the course of the last 3 years that we've moved our research and analytic into looking at the why of health status. And we accomplished a deeper understanding of the why by conducting a regional health survey in the summer of 2018. Where we reached 6,855 adults who live in the Finger Lakes region, and were really able to ascertain deeper understandings of their health journey, their health experience, and their health hopes, barriers, and aspirations. And I'm just going to spend a few minutes sharing with you 3 slides that speak to what I think are significant findings from this survey. This is the first of them. The fact that most African Americans who live in the Finger Lakes region, if you wouldn't mind going back, Prod, live in low SES neighborhoods. I live in the city of Rochester's 19th Ward. It is a very low-income neighborhood. It's the neighborhood in which I grew up. And I intentionally decided that I wanted to raise my children in the neighborhood in which I grew up. But that means that notwithstanding the zeros on the end of my paycheck, I and my family are exposed to the very same risk factors of crime and violence, of substandard housing, of differences in policing, differences in code and property inspection. I'm exposed to the very same conditions that low-income African Americans are exposed to. And I think we need to have a far more robust appreciation for the fact that Black people in our community, and to some extent Latinos in our community, have a very different lived experience than the rest of us. Because the rest of us watch news and what we see on TV is happening there. Whereas for people of color, those news events are happening where we live. Prod, if you'll advance. The next thing that I find very astounding is that we asked people if they would rate their mental and emotional health. And I was stunned to discover the real difference in terms of self-reports of fair at best or poor mental health. And I want you to know that when people talked about mental health, we asked 12 open-ended questions. So we have 12 times almost 7,000 responses, very robust qualitative data. When people talk about mental and emotional health in the Finger Lakes, what they mean is feelings of helplessness. When you have too much month and not enough money. Feelings of anger when you're just pissed off because you're sick and tired of being sick and tired. And feelings of destructiveness, either self-destructiveness or destruction towards others. And it reminds us of the question asked by the poet, what happens to a raisin in the sun? We have great reason to be proud that 90% of the adults in the Finger Lakes region told us that their mental and emotional health was good, very good, or excellent. It's only 10% who said fair or poor. But what happens, if you wouldn't mind animating the slide, Pod, is that when you start thinking about folks who live in low-income households, that number 10% becomes 24%. When you isolate to those who tell us that they live in an unsafe neighborhood, urban, rural, or suburban, 10% becomes 44%. And when we add on to that issues of transportation barriers, access to work or to medical care, 10% becomes 54%. And so my apology to you, my friends, is as the leader of your health planning entity, I've been missing the boat. I've been talking about the need to integrate mental and behavioral health with primary care. That's damned wrong. You need me to be talking about the fact that we can't do primary care. We can't provide specialty care if we're not addressing mental and emotional well-being. No wonder that my endocrinologist, when I go in for my diabetes checks, starts with asking the question, how am I doing? How is my wife doing? And how are the kids? Because that's where wellness starts. It starts in our hearts, and it starts in our minds. And if you wouldn't mind advancing, Pod, and what we have to understand, quite honestly, is we've been living with 401 years of a caste system in America. And quite honestly, as a community, we can be proud of the work you and your colleagues have been doing for decades, because it's shocking that the gaps are not worse than they are. And it has everything to do with the fact that you all have continued to make sure that care is the most important part of medical care. And for that, we are incredibly grateful. I'll advance, and I'm going to be out of your way in about 3 more slides. I will be out of your way because of the fact that, as Shakespeare said, well, the past is not the past. It is merely prologue. And what we are doing today is paying the reckoning for the history of who and what we are. And I will tell you, as a black man in America, I am incredibly excited and optimistic because of the fact that the work towards racial justice and racial conciliation is no longer being done by people of color alone. It is now being done by our white neighbors as well. And I am incredibly delighted, you can advance, right? Incredibly delighted as I share with my friends across the country that the day after the rioting and the looting that followed an incredibly impressive, peaceful protest and march for racial justice, that was an interracial march, that the cleanup was done the next day by a crowd that was just as diverse and representative of our region as the folks who marched. Kathy, I'm going to be done in 30 seconds and hand it to you. Pride, if you wouldn't mind advancing. So I would say to you that I am delighted to be here to join my colleague in having a conversation, to say to you that this is not just an information session, but this is a call to action. And it's a call to action each of us must respond to, because each of us has a unique role to play in helping to create a more perfect union. It is not just the job of Rochester Regional. It is also the job that each of us have and each of us share. If you'll advance, Prod, I think I have 2 more slides and I'm out of your way. The first is I would ask you to be incredibly aware of the fact that there is an incredibly impressive group of community leaders and activists and caregivers who have named themselves to be the Black Agenda Group. If you are unfamiliar with the Black Agenda Group, write down and go Google them. And the Black Agenda Group has made the declaration that racism is a public health crisis. That if we go back to that chart of the social determinants of health, they have explored and they have documented how racial attitudes and the implicit bias that Kathy talked about in her opening contribute towards the public health crises that we see. And in response to their declaration, you should feel incredibly proud that hundreds of organizations across the entirety of the Finger Lakes have endorsed that Black Agenda Group declaration and have passed similar statements calling on health improvement to recognize the urgent and pressing need to address structural racism and organizational racism in our community. One more slide, please, Rod. And I am going to do this last slide and then hand over to Kathy, because this is a slide of one of the blue chip commissions that we formed at Common Ground Health about 4 or 5 years ago. And we were incredibly proud that we had pulled together this kick-ass group of community leaders. And kick-ass is a term in political science that lets you know you've got juice. And we took this picture and we were going to publish it in our organizational newsletter until we saw what the picture looked like. And I hope you see what the picture looks like. It doesn't look like the Finger Lakes. And we decided we were not going to use this picture, but I use it because of the fact that it was an absolute reflection of how we define who's a leader here in the community. And our definition, without consciously doing so, our definition excludes people of color from having a seat at the table. And so we have redefined many of our internal policies and practices, many of the definitions and judgments we make, so that we never do this again. And I would challenge you, because I can guarantee you every Black person, every person of color in your organization does it the same way I do. When you walk into a room, you look and see how white it is. I challenge you to start doing the very same thing. And I challenge you to start speaking to each other. And then I challenge you to move beyond speaking to acting on it. Kathy?
Could you advance, Prod? So these bullet points come from the Institute of Health Improvement white paper on creating equitable care systems. And the first bullet point is make health equity a strategic priority at the level of the board of directors. Everything happens from the board of directors and the executive leadership team. And if this isn't high on their list, and I don't know if it is or isn't, then it doesn't trickle down. Develop structure and processes to support health equity work. And here, this is my add-in, look for and make disparities visible. Every practice, every department needs to be looking at their outcomes and process based on race and ethnicity. Decrease institutional racism within the organization, deploy specific strategies to address multiple determinants of health on which healthcare organizations themselves can have a direct impact, such as healthcare services, socioeconomic status, physical environment, and healthy behaviors. The white paper goes into great detail about how health systems can leverage their buying power to improve the socioeconomic status of vulnerable groups. And then develop partnerships with community organizations to improve health and equity. I do want to say here that not all of the things that we've talked about are within your ability to stretch out and mend. You can repair your relationship, you can look at your workflows and processes, but there are incredibly valuable and talented people in the system who are there to help you try to close gaps that are formed by social determinants of health for individual patients. Community health workers, financial counselors, social workers, they run the gamut. Next slide. Here are some local resources that you can access, and the Black Agenda Group website is here. So when you get this, if you want to look at it, I actually suggest you go to the website and read the group declaration, which is a very informative and accurate and impressive document. And now we can stop for questions. All's in your court, Prod.
Yeah, I've been advancing the slides, so it'll take me a minute to start looking at the questions.
Sorry.
Yeah, the questions, let's see here. There's an anonymous attendee who says, I would challenge the statement that we can't see our unconscious bias and claim instead that we choose not to see our biases, another privilege of bias. Any comment?
I would say that privilege permits us to be blind. But unconscious is unconscious. So they kind of, there's no argument there. That person is probably correct.
Yeah. So I just wanted to comment that the institution is doing something about this. They just recently appointed a chief diversity officer, a position that we have not had in the past, and also an associate chief diversity officer, Nana Duffy, who actually asks one of the questions in the group. So I saw her name on there and thought I should say that.
Yes,
so
and
Nana asks,
let me say something about that, Prod. That was on the slide, the new set of slides I sent that you didn't put up. They are, so Dr. Stamps, Dr. Duffy, and Dr. Bosbar are developing that office. And if you are interested, you can reach out to them with that interest. Thanks.
So Nana asked the question, why are the rates of COVID in the Black community so different?
I would say probably for a set of different reasons. First of all is the fact that we know that the virus is transmissible, particularly to folks who have underlying chronic disease states, including obesity, hypertension, diabetes, and those states exist at disparate rates within the Black and Latino community than the community at large. I'd say secondly that we know it's a highly transmissible disease that preys particularly on folks who are in high contact frontline service jobs, and those jobs are disproportionately held by Black and Latino and low income workers in our society. And then thirdly, which is a matter of a strong concern to me, is the fact that in older homes, and I live in a 1916 constructed home, older homes were not built for social isolating. There is no place in my home where there is a bathroom and a bedroom that's isolated from the rest of the household. And so as a result, those folks who live in older constructed homes tend to live in conditions that make spread of viral conditions very conducive. And again, that tends to disproportionately impact people of color and low-income persons. So it really is no surprise that we're seeing the numbers that we see. I would say, since I have the microphone, the surprise to me is that we're not seeing the death rates that we're seeing in other communities. And I think that has an incredible amount to do with the high quality of primary care, the high level of insuredness that we have in our community, and the pace at which over the last decade we have moved from just primary care to patient-centered medical homes as the model for primary care. So I have not yet the data to prove my point, but I really think that you all should really recognize the incredible role that you have played in not only improving and supporting health in this community, and I've got the data that proves towards hypertensive improvement in this region, but the unsung work you've done to protect our community from things being worse than they could be.
Emil, do you have anything to add to the epidemiology based on ethnicity?
No, I think Wade hit everything on the head. Sometimes, you have to be careful separating outcomes from incidents. And yeah, I think no. Thanks. There's a question by Dr. Lee at the grassroots level and clinic. What resources do we have? We are looking to. One of the things from the clinical epidemiologic standpoint, we are looking to create a registry. And that was initially started by one of the internal medicine residents. It's been moved to the System Incident Command. It's being supported by the quality informatics team. And so far we have 399 patients fully archived in there. We're working on ways to get it better automated because it's very labor intensive. And we hope, we envision that will be one of the resources. Currently, people can access it if they go through the IRB and get a very simple protocol that says, I want to access the data in the database. So more to follow on that.
So the remaining three on the question panel are really just comments, and I'll read them out. So Dr. Eskridge says, thank you for linking what we do as healthcare workers and health outcomes to all the policies we support in the national, state, and local level as the key to true change, which I think we would all agree with that. We need to this is from Stephen Webb, we need to consciously create the programs and opportunities in RRH to attract Black and Latino providers, which, yes, very true. And then Nana Duffy thanks you for the wonderful talk. And then I see one last one here that says, poverty kills and it may kill the soul. Poverty was brutally enforced on African Americans for centuries. The map showed it affects rural white people as well, leading to dangerous political tensions these days. How shall we direct our focus on racism and or poverty itself? That's a good question. Separate poverty from race. They're both important, I guess. Mr. Norwood, any comment on that? Or?
I would say that I quote the thinker who noted that the sign of intelligence is holding two contradictory thoughts at the same time. I think that we need to focus on race and racism, but at the very same time, we will not be able to change the political landscape if we are not able to create common ground, no pun intended, between urban communities of color and their rural neighbors. And that has really been the major part of my work since becoming CEO in the summer of 2018, is to make sure both communities understand that tyranny exists through the divide and conquer game, and that both communities have far more in common and far more to gain by working together than being pitted against each other for the long term. And my prayer is that this fall's political discourse, regardless of who wins, even though I have my own preferences, I hope that the discourse becomes a discourse by which poor folks, urban, rural, and suburban, and working and middle-class families discover once again that we are all in this together, and that we all must work together if we want to improve our nation, our state, and our community.
I'm going to make one comment to that, and that is that while poverty kills, if you're poor and Black, it kills more. And so the Common Ground has plenty of data on comparing the outcomes of poor white people versus poor Black people. Neither group does well, but the poor Black people have worse outcomes than the poor white people.
On that note, I think I'm going to call this a grand rounds. Thank you so much to the panelists for their participation.
Thank you, Dr. Fatak.
And a tape of this will be available on YouTube for those who couldn't make it. So I'll send that tape around at the end of the day. And Dr. Lesho's epidemiology slides will be emailed to anyone who wants them. So with that, thank you very much and see you all in 2 weeks.
Okay.